Hi everyone. Thank you so much for being here. We're a small group, but thanks again for being here, and thanks Laila to agree to present to us your research. So my name is Laila Chaudhry. I'm a research coordinator at the Quebec Pain Research Network. So I'll be in charge of moderating today. So let me just skip to the next slide. Awesome. So today I have the pleasure to introduce you, Laila Chaudhry. I hope I pronounced your name well. Awesome. And Laila, she's a Canadian-American sixth-year PhD student at McGill University, and she's working with Dr. Jeffrey Mogul and Dr. Charlotte Uzelman. She's interested in social neuroscience and psychophysiology of pain, and her current research examines how the autonomic system interacts with the modulation and propagation of acute and chronic pain, and also how this varies across sex and gender. So maybe we'll look a little bit more into details today into that. And before I let Laila share her screen and start her presentation, I just wanted to remind you a couple of logistics. So during the presentation, it's recorded. Please keep your mic closed so we can have a nice recording at the end. It's going to be available on YouTube and also on the AQDC website. But if you have any questions, please feel free to write them down in the chat, or I can read them at the end, or you can also unmute your mic and then ask Laila yourself your questions. And again, as a reminder, we won't be able to discuss any personal questions today, so please just make sure that your question is related to research and pretty broad or general, so we'll be able to address that. So I'll stop my screen sharing and I'll invite Laila to share her own screen.
So thank you guys for being here. Today I'm going to be presenting what I've been working on for my PhD thus far. So as Yulia kind of described, my PhD is looking at how sympathetic markers can be used as biomarkers of pain. So specifically, I'm looking at how sympathetic outflow can be used as a biomarker for pain propagation and modulation. So a little bit of a background about what we're going to talk about. I'm going to talk about the current pain field, some of the limitations that we have currently in measuring pain and why we need biomarkers. Talk a little bit about two specific biomarkers, conditioned pain modulation and muscle sympathetic nerve activity, and then how pain is modulated through sympathetic autonomic mechanisms. And then I'll go into talking about my studies a little bit further, and so we'll get into those later. So what is pain and how do we measure it? So pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And so the way that we measure pain is generally categorized into three broad areas. So the first is self-report. So this is scales and questionnaires. If you've ever had a doctor ask you to rate your pain, this would be, on a visual analog scale, numerical rating scale, so from no pain to worst pain possible. And then we also have a certain questionnaires like the pain catastrophizing scale, McGill pain questionnaire, etc. And so there are some limitations with these methodologies. For one, they're highly subjective to the individual's pain experience. So for instance, one of the examples is in an experimental context. This Kim et al. Study administered a 49 degrees Celsius heat pain stimulus to participants. And on a scale from 0 to 100, they rated the same pain stimulus all the way from 5 to 95. So really, really high variability in the experience of this one stimulus. Additionally, So that's inter-individual variability. At the intra-individual level, if you go from one visit to another visit with a doctor and you have a different mood state, or there's something else going on, there's a lot of intra-individual factors that can change your pain rating from day to day as well. So again, this plays into the subjectivity of these methods that we're using. Additionally, self-report does not have high dimensionality. So shown here are some artist renditions of the chronic pain experience. And, a simple rating of no pain to extreme pain or worst pain possible does not truly capture the multidimensional experience of pain, especially chronic pain. So in other ways that we measure pain, particularly in animals, babies, or nonverbal individuals, we use observation methods. So this methodology here is referred to as the mouse grimace scale. So I don't know if you're familiar, but animals do have scales that are used to measure their pain based on their facial expressions. And so my supervisor, Jeff Mogul, is well known for this. Additionally, we have observable measures of pain in humans as well, as you can see here, this Perkichin paper. But there's also limitations with this methodology. So pain observation it lacks specificity ultimately. So you can typically detect the presence of pain, but you cannot necessarily specify how intense or how unpleasant that is. So on these spectrums, you're unable to really measure how intense that pain is ultimately. And all you can really say is, oh, they have pain, but we don't know how much pain they have. Additionally, measuring pain behaviors is an indirect way to measure pain. We have, this is referred to as the Fordyce behavioral model of pain. And so at this base level here, we have nociception, which is sort of that nerve impulse of pain. And then we have actual pain itself. Then we have suffering, which separates pain from pain behavior. So individuals might be experiencing pain, but if they're not displaying pain behaviors, how do we know that they have pain? So it's an indirect way of measuring pain, unfortunately. Finally, we have biomarkers of pain. So shown here is a fMRI biosignature of what pain looks like in one particular study, as well as a number of methodologies that are related to autonomic research, so respiratory rate, ECG, blood pressure, which can be considered biomarkers of pain as well. So a biomarker is defined as a characteristic that can be objectively measured and evaluated as an indicator of a normal biological process, a pathologic process, or pharmacological and non-pharmacological response to a therapeutic intervention. And so we have a number of biomarkers that we use in research, particularly pain research. One common one that's used is EEG, or electroencephalography, which is where a cap is placed on a participant or a patient, and you measure cortical brain waves. Neuroimaging, so fMRI or MRI as well. Some individuals look at epidermal nerve fiber density. So there is some evidence that loss of small nerve fibers or increased amounts of nerve fibers can be related to chronic pain in certain conditions. Genetic factors as well. And then the two that I'm going to be talking about today, which are quantitative sensory testing and microneurography. So my studies are, my first study is conditioned pain modulation in humans is dependent on test stimulus intensity. So conditioned pain modulation is elicited through quantitative sensory testing. So that one of those biomarkers I was talking about. So what we do when we bring an individual in, sometimes this is done in a clinical context, sometimes this is done in a experimental context. An individual receives 2 pain stimuli at different parts of their body, and the one is considered the test stimulus, the one that is applied first, and then the second one is considered the conditioning stimulus. And ultimately, what we'll do is we'll apply the test stimulus, then the conditioning stimulus, then the test stimulus again. And what we want to see is how this individual reduces their pain perception of 2 stimuli together as opposed to one. So this is kind of this old adage. I don't know if you ever had a toothache and your grandfather told you, oh, come over here and I'll hit you on the toe with a hammer and that toothache will go away. That is, sort of a colloquial version of conditioned pain modulation. This is a scientific phenomenon. So ultimately, the body has these endogenous pain mechanisms, and conditioned pain modulation is supposed to be an indicator of your body's internal ability to regulate pain. So 2 pain stimuli together are supposed to actually have a reduced pain intensity or perception as opposed to just one by itself. So this ability, your body's internal ability to regulate pain perception is considered to be a predictive biomarker for the development of chronic pain. And so there is some evidence that low CPM efficacy reflects low capacity to inhibit pain. And this can predict the onset of chronic pain. So some background, currently in the field, there's no set standard methodological protocol for CPM. So we see really high variability in healthy participants. So it causes issues when we try to sort of compare data across multiple studies, because again, people are doing it with different ways. There's very little literature that exists on the effects of variations in the test stimulus. There is a decent amount of evidence for variations in the conditioning stimulus, which is the second one. But as far as the test stimulus goes, there's almost no literature at all. So my lab, which also works with mice, does believe that variability in the test stimulus can sort of predict this variability that we're seeing in these studies. So previous mouse data demonstrates that test stimulus intensity affects CPM's direction. So in studies that used a high intensity test stimulus, we saw the CPM phenomenon. And in studies that used a low intensity stimulus, we saw actually increased pain. So when we're doing these CPM protocols, we have to use sufficiently painful stimuli, or else you're not going to see conditioned pain modulation. So you can't use low threshold stimuli, essentially, or you will see increased pain, hyperalgesia. So the aims of our original study was to determine whether test stimulus intensity was associated with CPM direction in humans. And then our secondary aim is we want to see how this, anti-CPM phenomenon, this hyperalgesia, presents itself in chronic pain patients, because of the fact that chronic pain patients are supposed to have dysfunctional or altered endogenous pain mechanisms, essentially. So we wouldn't expect to see this phenomenon at all. We would expect to see it either reversed or just completely abolished and replaced with hyperalgesia. And so what we went on to do is we recruited 60 undergraduate participants from the McGill population, and we obtained their heat pain threshold. So what we did is we ramped a heat thermode, which you can kind of see right here. We did 4 successive temperature ramps, and we had them click on a mouse every time it got to when it was painful, and we took that as their pain threshold. And the average temperature of those 4 was calculated as their pain threshold. And then we went on to either add -1 degree Celsius, +1 degree Celsius, or +3 degrees Celsius to this temperature, and conducted a CPM trial. So what you can see here is that we administered one heat stimulus, then another heat stimulus. We took the average pain rating from that, and then we did a cold pressor test, and then we did the pain stimulus again. And so what we wanted to see is how individuals' pain ratings changed from the, sorry, I can tell that my green screen is really acting up and I'm like going in and out here. I'm just gonna try and fix that really quickly. Okay, let's hope this works. I'm just gonna lean in. Okay, so we then wanted to see how their pain ratings changed from the post cold pressor test to the from the pre-cold pressor test to the post-cold pressor test. So we did post minus pre, just to see what their CPM looked like. And so these were our results. So we had stimulus intensity dependent CPM. So this is a little bit chaotic to look at, so I prefer to look at it like this personally. And so you can sort of see in this category that this -1 group had increases in their post-CPT pain rating. So we started to see this at a sub-threshold, at an insufficiently painful stimulus. We saw these increases in their pain, rating. So we saw hyperalgesia, as opposed to this +3 group, where if we used a stimulus that was sufficiently painful, we actually saw the CPM that we would expect to see. And so this linear trend is actually statistically significant. So this is really good evidence of the fact that we need to standardize our CPM protocols in order to have an understanding of what CPM looks like in an average non-chronic pain population, so that we can then apply these to chronic pain patients as well. So currently this second part is ongoing. We are looking at trying to recruit 60 individuals living with fibromyalgia from the Allen Edwards Pain Management Unit. So from the affiliated pain management unit with McGill University. And so this protocol would mirror protocol 1 exactly the same. And so we would do a pain threshold assessment, a CPM trial, and then assess using this additional temperature change. Unfortunately, we only have about 6 participants, so the results are not super great, so I won't be presenting those. There's really nothing to look at there yet, unfortunately. But I'm really excited to see what this looks like, because I think that it will be really good evidence of this phenomenon in both a healthy participant population, but then also in a patient population. So my second study is looking at the relationship between subjective pain ratings and sympathetic outflow during a cold pressor test. Just give me 1 second here. Can't tell if that's making my green screen worse or better. Okay, we'll try this. Nope. 1 second, I'm so sorry. I don't know why my face is turning gray, unfortunately. Unfortunately, I have to do this in my bedroom at home today. Okay, so my second study is looking at the relationship between subjective pain ratings and sympathetic outflow during a cold pressor test. So this other biomarker that I was referring to earlier, microneurography, is a neurophysiological method in which a conductive tungsten needle microelectrode is inserted into the peripheral nerve of an awake human subject and used to record and visualize the traffic of nerve impulses. So I know that's a lot of jargon, so I'll kind of explain what that looks like. We'd lay a participant on a sort of padded table bed, something that you would see like in a physical therapy clinic. And what we do is we support their leg with foam, and right at their knee, we insert sort of like an acupuncture needle. And this is aimed at the peroneal nerve in their leg. And what we are attempting to do here is to record nerve impulses in response to cold pressor tests as well as at baseline. So this methodology can be used at the hand, at the foot, at the elbow for different things. So Jordi Serra is a individual who uses microneurography to study pain. And what he does is he records unmyelinated afferent C fibers. And in individuals, healthy individuals, these C fibers are silent. So there's no spontaneous activity until a noxious pain stimulus is applied to that body part. But in individuals with neuropathic pain, they actually have spontaneous activity in their nerves. So there is evidence that microneurography can record actual pain impulses. Microneurography can also be used to record what is referred to as multi-unit sympathetic efferent fibers. So what this actually is descending sympathetic activity, or the body trying to modulate responses to pain or sympathetic stimuli. So muscle sympathetic nerve activity, which is specifically what I am looking at in this study, is heavily controlled by homeostatic baroreflex mechanisms. So what does that mean? It's related to your body's homeostasis of trying to control for blood pressure. So it's related to the cardiac cycle, and it has a relationship with blood pressure variations. And there is a decent amount of evidence that it generally increases when a participant is exposed to a painful stimulus. So some of these stimuli in the past have included instilling soap solution in the eye, nail mechanical pressure, mechanical skin pressure, and then the cold pressor test as well. So some background: because MSNA generally increases to an acute pain stimulus, it has been proposed as an objective biomarker of pain. However, acute pain's effect on sympathetic outflow has been looked at significantly, but the long-lasting pain, which is more clinically relevant, has not been correlated with MSNA sufficiently. There's very little research or evidence for this. So the primary aim of this study is to examine the relationship between changes in MSNA and changes in pain ratings during a 6-minute cold pressor test. And so what we hypothesize is that MSNA and pain will be positively correlated, and that they would both increase steadily and concomitantly through a 6-minute CBT. And so what our protocol consisted of is we had the participant lay on the bed. We measured blood pressure, heart rate, MSNA consistently throughout, and we at baseline took a pain rating. Then we administered a 6-minute cold pressor test. This is them putting their hand in ice water for 6 minutes, which, having done it, is wildly uncomfortable. And we had them rate their pain at 30 seconds, at 2 minutes, 4 minutes, and then 5 minutes and 30 seconds. And then we had them take their hand out, and we recorded recovery for 10 minutes as well. And pain ratings consisted of verbal pain ratings from 0 to 10, 0 being no pain and 10 being the worst possible pain. And so these are the preliminary results. We have collected 20 participants. Half of them have been analyzed at this point, and so you can see them here. So this is how pain changes across time in our participants. As you can see here, people's pains were at 0 or near 0. and then increased significantly during those first 30 seconds of the cold pressor test, and then remained fairly steady across time. MSNA also increased significantly during the first 30 seconds of the cold pressor test, and then sort of continued and then went down just a little bit. Neither of these, excluding these first 30 seconds, neither of these significantly changed across the 6 minutes of the cold pressor test. So here you can actually see the relationship between, and I apologize, these graphics are not particularly intuitive, so I'll do my best to explain them. This one on the left is looking at the positive relationship of each individual's sort of slope in between their pain rating and their MSNA across time. So each individual slope is shown here. And what we did is we time matched each pain rating and each MSNA, sort of burst incidence is how that is calculated, burst per 100 heartbeats. And we just showed that there is a decent positive relationship between these two. Additionally, we did a repeated measures correlation, and you can see these values here. So obviously, this is a very significant relationship between MSNA and pain during those first 30 seconds, which I previously described. And then interestingly, we see a negative relationship between it, and it's fairly weak. And then it goes back to being significant again during the 2 to 4 minutes. And then it goes back to being negative. So this kind of started this question and this further exploration, which leads to my third study. So we wanted to kind of understand why we were seeing almost this fluctuation, similar to the way you would see fluctuations in almost like blood pressure, up and down, up and down. So what I wanted to look at was the baroreflex regulation of conditioned pain modulation. So the baroreflex is just a homeostatic mechanism that looks at how your blood pressure goes up and down. Essentially, it's cardiovascular reactivity to either stressful stimuli or just making sure that your blood pressure continues to vary and sort of stay fairly constant with little fluctuations inside. So baroreflex modulated pain, there is some evidence for this. So individuals with hypertension, family history of hypertension, and even normotensive individuals with high resting blood pressure have actually been shown to have decreased pain sensitivity. Additionally, electrical stimulation, carotid suction, or the pharmaceutical manipulation of baroreceptors, so those are at your aortic arch in your heart, as well as your carotid artery in your neck. These lead to anti-nociception. So you see, again, reduced pain when stimulating these baroreceptors. And then finally, individuals who were undergoing stressful tasks and had blood pressure increases to these stressful tasks, when they then received a pain stimulus, they had stress-induced analgesia as well. So the stress-induced analgesia is a reduction in pain due to stress. So a little demonstration of how these mechanisms might work. There is a decent amount of overlap in your pain regulation and in your sympathetic anatomy. So interestingly, we have this construction worker here who has hit his finger with a hammer. So he has ascending pain information going up to the nucleus tractus solitarius, which is an area in your brainstem, the periaqueductal gray, another area in your lower brain and brainstem, and then also higher areas in the brain, such as like your thalamus, hypothalamus, etc. And so this somatosensory reflex is going to increase sympathetic arousal. So what that means is that it's going to send signals that are telling your body fight or flight, fight or flight, fight or flight. and that's a descending activation. So this is going down and it's triggering sympathetic activity here. So blood pressure is going to increase. You have an increase in blood pressure, and that is going to stimulate your baroreceptors, which are essentially little sensors on your carotid artery and your aortic arch, which are essentially looking at the pressure in those vessels. And they want it to stay fairly constant, so they're constantly going up, down, up, down, up, down. And so you can sort of see that here as well. This is a little bit of a demonstration of how blood pressure stays constant, but with internal fluctuations in sort of that mechanism. And so what is going to happen is this baroreceptor activation is going to come back down, and it's going to trigger descending pain inhibitory activity through your rostral ventrolateral medulla. And so this is essentially a negative homeostatic feedback loop, which is showing that this sort of descending pain is going to be assessed at the sort of receptors of your pain afferent mechanisms, or your pain sensors in your body. And it's going to say, okay, we've decreased pain enough, so we're going to stop. Or it says, oh no, we're still feeling a lot of pain, and it's going to continue the activation of this. So it's this homeostasis mechanism that's continuously going when you're experiencing pain. Interestingly, there is some evidence that this homeostatic mechanism is reversed, though, in individuals with chronic pain. So there's some theories on this we'll go through, and then I'll kind of talk a bit more about it. So it's shown that experimental stimulation of those baroreceptors in individuals with chronic back pain led to increased sensitivity to electrical pain rather than the decreased pain that you would expect to see in pain-free individuals. In diverse chronic pain samples, resting blood pressure was unrelated to reactivity in acute pain stimuli, and in some cases was positively associated. And as I said before, we would expect them to actually be negatively associated. Additionally, post-surgical chronic pain patients have almost twice the prevalence of hypertension than patients without pain. So there is some evidence for cardiovascular health issues in chronic pain patient populations. And then finally, there is some evidence that shows that this positive relationship between blood pressure and chronic pain progresses over time. So there might be gradual changes in baroreceptor function. And so the theory behind this is that if your body is constantly telling you pain, 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 you're constantly activating that sympathetic mechanism, it's burning itself out. So you're getting exhaustion of this sympathetic mechanism, which is resulting in exhaustion of the pain inhibitory mechanism as well. And that's why maybe we see reduced CPM efficacy in chronic pain individuals. So my study the next study that I'm proposing is going to try to look at some of those mechanisms. So cold pressor test is widely used for both CPM protocols and autonomic testing. And reduced blood pressure response to conditioning stimuli has been linked to less effective conditioned pain modulation mechanisms. So this does suggest the role of the sympathetic system in the mediation of pain modulation. And there are currently no studies investigating the relationship between MSNA, so this sympathetic descending signal, and conditioned pain modulation, this descending inhibitory pain signal. So my proposed methods, we would start with a healthy patient population. We would get healthy participant population. So we would start with 14 participants, 7 men, 7 women. No history of autonomic disorders, endocrine disorders, or chronic pain. And then we would do microneurography. We would assess blood pressure and heart rate continuously through data collection. We would then do a pressure pain stimulus, or recently changed this methodology to maybe being a heat pain stimulus, just to be consistent. And so we would do the same sort of protocol that we saw before. We would do a pain threshold assessment. Then we would do the CPM protocol, which would be 2 pain stimuli and then cold pressor test and then a final pain stimuli, and assessing pain from pre-CPT to post-CPT. And we would be assessing pain using visual analog scales, numerical rating scales throughout. And so we would hypothesize that we would see increases in sympathetic activation, specifically MSNA, during the post-CPT pain stimulus, but this would be associated with a reduction in pain ratings ultimately. And so we think that in healthy participants, we would expect to see this negative relationship between sympathetic activation and pain. And if we continued this study and did it in individuals with chronic pain, we would likely see the opposite. We would see increased sympathetic activation as well as increased pain. So in conclusion, there is a substantial unmet need for validated biomarkers of pain to better study and treat chronic pain. Pain dysregulation and pain inhibition mechanisms likely does involve the autonomic system due to the overlap in structures in the brainstem as well as the brain. So further exploration of this overlap between these two phenomena does have the potential to create new knowledge, open the door to several new perspectives, and help advance us down the rigorous path of developing and validating new pain biomarkers for studying and treating chronic pain. Questions, comments?